Hello, hello. Is it going? It is not going. Hello. Well, this is not the forum that I love, but I'll try to be loud and available. Um, First of all, there's so many familiar faces, so with HIPAA privacy laws, I won't out you all, but as I said, this is like a room full of my peeps. Everybody looks very familiar. A lot of veterans here in the room. Many faces I've seen for many years, and some of whom I've seen in my clinic. So welcome. I will start this out by telling you what I told the other group, is that this was probably the most challenging topic I've asked to speak on. I'm going out with a bang. I've been here 5 years, and generally I like to have a conversation, something informal. We can talk about experience. We can still do that. But this topic to me lent itself to slides because I can't just informally discuss research. To me, um, I will also tell you that in addition to wearing a clinical hat and an administrative hat and a teaching hat at Hopkins, I also, for the last 2 years, am a board member of the Institutional Review Board. And I'll tell you about IRBs or Institutional Review Boards, but they oversee all of the protocols in the university that are both clinical trials, interventional trials, anything involving human subjects research. So I have a lot of experience from a background in that way as well. And I will open the meeting up first, and can everyone hear okay? The acoustics are not good. Yeah, I will open this up there we go, to ask you if there are specific questions before we start. I mean, I don't want it to degenerate, but if there are specific questions, just to get the conversation going, and then I have got a bunch of slides that I thought were important to orient you to research. Please.
Some of the research that's out there right now, people are talking about the stem cell research, also the ACTAR and how that's administered, and if there, whatever else is going on as far as clinical trials are concerned.
I have those slides for you. With regard to stem cells, I'll just, as an aside, there is a stem cell research trial in non-IBM. So the stuff that was talked about this morning is not human subjects research, but it is clinics and other centers popping up offering treatment outside the realm of a human subjects research clinical trial. So I would be careful to know the difference between a clinical trial and offered therapy out of that. But I'll highlight those. I highlight for you today all the trials that are on clinicaltrials.gov, which is the main US site to help access those trials. Actually, there's a misspelling on my slide later. It's clinical trials. I missed the I think. Clinicaltrials.gov, so all one word. And at the end, I'll highlight specifically the US trials recruiting, including those that we're recruiting for at our center. Question? Anybody else?
Okay, what are the new medications, or are there any new medications now for polymyositis?
That's what we'll discuss, is the experimental trials that are going on today. That's what you're here to see, and I'm going to show you those slides in a bit. Yes, the names of the medications, that's correct.
Will all your slides be on the TMA site, or I'd like to take notes, or I just like to absorb it?
Yes?
Okay.
Yes.
Yeah, thank you.
I don't know that they can yet because I just gave it to them, and yeah, so, well, you know, I'm a busy lady. I was changing my slides till the minute before I got here, and then I missed my spelling error. All right, anyway. So whether I need to disclose it or not, I'll tell you that I'm a clinical trial investigator and or a medical advisory board member. I am not on the speakers bureau for any drug company, pharmaceutical company, industry, except I am a board member. I'm sorry, I have been a consultant or an advisory board member for Novartis, Idera, and Questcor, all of which have some relevancy today. Okay. So I open it up, and I don't mean to sound like a school teacher, but I thought we should all be on the same page, and so that you can understand a very quick primer of clinical trials. So what are our clinical trial phases? How do they affect you? What are they? Phase 1. This is a trial, this is a phase of clinical research in which researchers test a new drug or treatment, so it could be exercise, some treatment group, in a small group of people for the first time, in order to evaluate its safety, determine a safe dosage range, and identify side effects. Small group of people, phase 1. Less likely that you'd be involved at that level, although we do phase 1 trials. These are much more intense as far as safety signaling and often don't have many people recruited into them. So this is the first phase. Phase two, more likely for you to be recruited for, is when the drug or treatment is given to a larger group of people to look for efficacy and to further evaluate its safety. Phase three. This is a bigger group. So this is the most common group in which the drug or treatment is given to a large group of people in order to, again, confirm effectiveness, confirm this time, monitor for specific side effects, compare it to commonly used treatments, and then collect information that will allow the drug or treatment to be used safely for the masses of people. And then finally, phase four, this is essentially like a post-marketing phase. These are studies that are done after the drug or treatment has been marketed. Then the reason that we do this is that we sometimes don't see initial safety signals in the beginning, and we need many years out to say, oh, we didn't realize that in various populations and any side effects associated with long-term use. An example of that was when the TNF alpha inhibitors came out, tumor necrosis factor inhibitors, such as etanercept, infliximab. I'll speak to that briefly. For rheumatoid arthritis, it wasn't clearly appreciated that if you had been previously exposed to tuberculosis, these drugs were unroofing that, and they're causing people to express tuberculosis where they hadn't ever expressed it before. And that was really seen when you had more people to be able to observe that effect. Okay, here's your glossary today. There will be a quiz. No, I'm kidding. So blinding, right? So I think most people appreciate the concept of blinding, but I once had a conversation with a patient when I said that the doctor would be blinded, and they looked horrified. So I'm going to be clear that blinding, also known as masking, is when the treatment assignment is not known to someone. It's either not known to you, or not known to the doctor, or investigator, or not known to both. And that's double blind. Double blind is when neither the physician, investigator, whomever is conducting the trial, nor the patient know the assignment, placebo or usual care versus new therapy. Got it? Placebo. We all understand placebo. An inactive substance or procedure, but I want to be clear that a placebo can be a procedure, and this is an idea of something called a sham procedure. This was first, I think one of the most, in our prior group, I shared with them that when I was training, a New England Journal paper came out regarding sham surgery for people with osteo or degenerative arthritis of the knees, and whether arthroscopy, going in, the clean out with a little scope in your knee, was actually effective. And they did a sham procedure as well as a real procedure. So you sign your consent to be able to be in this procedure. And one group had the surgery in which they went in, irrigated with water, cleaned out the knee, cleaned out stuff in there. This is my orthopedic view of things. Or they just made a little cut in your knee and didn't do anything in there. But you equally had the same surgical scar. One person had the procedure, one person did not, or those groups. And they showed that the sham surgery was equal to the real surgery. And this was the first time that we thought, well, maybe that arthroscopy for knees is not as effective as we thought. So it can be a sham or a control treatment as much as a drug. Equipoise. Equipoise is a term in clinical research. Essentially, it's a term in general, but in clinical research, it means equal balance of weight. This means that in order for us to do a trial ethically, we cannot know that a particular drug works better than the current standard of care. We may think it does, but there's no clear indication that we know a drug works better. And if we find midpoint by evaluating that we did see a signal where something looks either toxic or the reverse, helpful, often the study is stopped early in order to provide everybody the therapy if we think there's such a good clinical signal that the trial should not go on. Informed consent is your consent to undergo research procedures after receiving materials that carefully outline for you known risks, benefits, and alternatives. And this is in the vein of the stem cell story that was discussed this morning. Ideally, truly, one should know the true risks, potential benefits, if any, and alternatives to using a specific therapy, and carefully vet that against what is currently known. In the case of IBM, because we all know, it's ethical to include a placebo group because there's never been any true medication shown long-term to be helpful in IBM. So that's an ideal cohort of patients to study because an ethical group, placebo, truly nothing, right, using nothing, is an ethical group in that case, whereas arguably dermato and polymyositis, to use a true placebo group, is not ethical if we know that steroids, for example, should work as the background therapy. And so everybody can get steroids and still be in the trial. What's an institutional review board? I told you that I'm on one. These are a small group of people, generally consisting of physicians, pharmacy, and therapeutics. There's usually a member from the community, like clergy or otherwise, that comes from the community perspective, consent form specialist, and legal representative, almost always an attorney. We are authorized to approve, request modification, or disapprove research activities and to conduct continuing reviews of this research at a specified interval. And usually it's a minimum of 1 year, where we make sure that not only what we approved initially is good, but it's ongoing and still appropriate. This is for all human subjects research. This does not apply to vertebrate animals, mice, deceased people. That's under different rules and laws. Okay, now here I have to read my own slide this way. So protection of human subjects. This is long and involved, but what you should know is that we have produced, scientific research has produced great societal benefits, right? I'm sorry, scientific research has produced great societal benefits, but it also has ethical questions. And a lot of those ethical questions were born out of the world around the time of World War II with biomedical experimentation. During the Nuremberg war crime trials, the Nuremberg Code was drafted as a set of standards for judging physicians and scientists who had conducted biomedical experiments on concentration camp prisoners. This code was the prototype of many later codes intended to assure that any research involving humans would be carried out in an ethical manner. But the codes consist of rules, some general, others specific, that guide investigators or the reviewers of research in their work. But there were inadequate scenarios, and we had to cover more, and research became more complex. So in order to ensure that research that was done was truly ethical, we have the Belmont Report. 1972, there was a commission that said, we're not doing a good enough job. We need to be very specific, making sure that people that undergo research are protected. I promise I'm getting to the trials in a moment, but I want you to understand what goes into this. I think it's important. So develop guidelines to be followed by anybody that conducts clinical research on human beings to ensure that research is conducted in accordance with 4 principles. First principle is that the boundaries between biomedical and behavioral research and the accepted and routine practice of medicine are clear. What is usual care, what is research, and what is not. I gave the example previously that say a physician feels that something works and he or she develops a new device, and they test it on their family members, and they use that initial data and they submit it to us, and they say, this is the pilot data for us to go forward. This is the impetus for us to want to use this device in more people. Well, that original research on their family members was not conducted in an ethical manner. You cannot do that. You can't use that data as research data. You actually have to have the consent of even your family member. A physician actually can't do something on themselves. I have to consent myself. Someone else has to consent me. I cannot do in the old days where we did experiments sort of on ourselves to prove something. Can't swallow toxins, can't do those things because it's actually not protecting even the investigator. The role of assessing risk and benefit criteria and the determination of appropriateness of research. So always there's a balance. On balance, we sit in these meetings and say, is it worth the risk? Should somebody undergo that risk? Should we include certain people? Should we not? Is it too risky to include pregnant women? Should somebody who's nursing not be in this trial? Is it wrong to not include women or pregnant women or somebody with cancer or X, Y, or Z? What is the ethical nature of disapproving or approving, allowing rather, someone in the trial? Appropriate guidelines for the selection of human subjects, again, more of the same, and then nature and definition of informed consent in various research settings. This says that you put your signature, usually it's written, sometimes oral, you are informed of the nature of the trial. So you sign saying that you have read, been told about, and comply with what we intend to do so that you are protected. Okay, so the inclusion in a trial for myositis, for this group, we're talking about poly and dermatomyositis only, but why might you be excluded from a clinical trial? Well, maybe your disease severity is actually too mild. If you have too little disease, here we're talking about muscle as an example, this can be lung, this can be skin. If your disease is actually too mild to be included, you might not be included because A, it doesn't seem ethical or appropriate for you to try a drug or an intervention when others exist. But even if they don't, and you're not responding to conventional therapy, but your disease severity is too mild, we might not see enough of a signal, a difference of a separation of the groups between those who are treated and those who are not. So you might be too well. You might be too sick. And if you're too severe and you have, for example, such bad muscle disease that you have anti-gravity strength, you can't lift even against gravity, that may be too much, and we're afraid that what will happen is we will have the potential not to bring a drug to clinical marketing for marketing because we tested it in too sick of a population. It's not that the drug doesn't work, it's the population wasn't appropriate in which we tested it. So we don't want to not have a drug allowed to further to be used for more people because we chose the wrong subset. Usually we eliminate you if you have an overlapping disease. If you happen to be unfortunate enough to have another autoimmune disease, which is not uncommon because they travel in pairs, Sjogren's syndrome, for example, which is autoimmune destruction of the lacrimal glands, the tear glands, and the salivary saliva glands, is one that frequently travels in pairs with our diseases. Then lupus, rheumatoid arthritis. And why? Because it's hard to separate out the response and making sure that one of those diseases isn't influencing the response of the potential therapy. And we also don't want to make those things worse. If you've ever had cancer, you're often excluded from a trial. Most trials will allow you to be in a trial if you've had a malignancy that's greater than 5 years out. But that is trial specific. But a lot of trials will eliminate you if you've ever had a malignancy. It also depends on what malignancy. In general, most malignancies are excluded, but some people will say that basal cell carcinoma is actually allowed in, which is usually relatively, although it's malignant, it's a relatively treatable form of skin cancer. And then other medical conditions specified by the trial's inclusion criteria. Maybe the drug has some toxicity to the liver, and they will not allow you in if you have any elevation in your liver function tests, for example. And concurrent or previous use of some medications, specifically use of monoclonal antibodies, something like rituximab, often eliminates you if you've used it in the recent past because the effects are a little bit longer. So we do what's called a washout, and it's unclear how long it takes to wash out these antibody effects from your bloodstream. I've just said a lot. Before we go on to looking at the specific meds that you've asked about, any questions about the background of participating in a trial and understanding things? Sure. I think I got one here and then one there. Oh, okay. Sorry. What's that? These are United States standards. Well, actually, the Belmont report refers to the U.S. There are very similar clinical standards that are performed internationally, but the Belmont report was designed for U.S. studies. Yes, I'm sorry.
Yes, it's also to his question about international trials. I mean, I know it's all of, with the US at this point, but I live in Basel, Switzerland, and I actually can see the Novartis headquarters from my window. But it's such a bitch, if you excuse my French, trying to get into a clinical trial.
In which way, if I may ask you, because I truthfully don't have experience
internationally.
I mean,
I suit all the criteria there. And I have looked on the clinicaltrial.gov, and it's always US only, or
So it's the availability of the
exactly,
trials,
yeah.
not necessarily getting in.
It's a little bit biased to its people living in the US, and anywhere else you just don't get into a trial.
Is that true? That's
Yeah.
interesting. Yeah, I'm so US biased for obvious reasons. I can't believe you live in Basel, right? You could go to Novartis and sit with them there and have them infuse the drug. No, I'm kidding. So yeah, I don't have a great. That's something that I had not contemplated or know a whole lot about. I agree with you that most trials are done in the U.S. There are some, which I'll show you. There are some international trials just to give you a flavor for what's going on. Many of them are done in Sweden because Dr. Ingrid Lundberg, who's a tour de force, I call her the queen of myositis, does quite a bit at the Karolinska Institute in Stockholm. And and I think that was spoken about this morning, just to review, investigator-initiated versus industry-sponsored or industry-initiated. I can introduce a trial where I, as an investigator, want to study drug X with drug Y, and then I pitch it to the company or to the NIH or to somewhere and say, look, I need the funding to be able to run this trial. And sometimes the pharmaceutical industry will sponsor giving the drug. But what's unclear, what I did not appreciate before trying to embark upon these trials is how expensive it is to create an identical placebo. So when you give a therapy, you must, if you're going to do a placebo-controlled trial, give something that looks identical, bioidentical, looks the same, tastes and smells sort of the same, so you really truly are blinded. It's not as easy as you think. If you have an oral therapy, it has to look exactly like the oral therapy, and that creates a lot of it's a lot of funding to do that. So simple things like that. But most trials are industry sponsored, but we also have some hopeful stuff with investigator sponsored trial in the pipeline, which I don't discuss today because they're not up and running. Please.
England does a number of studies, is that correct? Also?
England? Clinical trials, no, not that I'm not familiar with. Studies, yes. They do some genetic studies there. There's something called Euromyonet, which is not just England, but I'll show it to you. It includes, I think Yuri Venkoski this morning talked about this, and there's a nice network at Prague, the Czech Republic, Sweden, UK, because European countries have to band together to get the numbers. But specific trials to the UK that are pharma sponsored, I'm not aware of. I am sort of U.S. based. I wasn't ready to talk about the international community. I'm not sure. I'll be honest. I'm not that versed in what goes on there. And it's current clinical trials. Okay, so these really are. This is a laundry list of trials. We'll go over why they might be important, do they matter to you, and what might be coming down the line. So the first is something simple, effects of exercise training, and this is done in Sao Paulo. This is not, it's theoretically recruiting. It's going to end in December, so it's not a US trial, but this is one in which they think that exercise may improve physical capacity and health parameters in primary Sjogren's syndrome and myositis. So this study aims to investigate the role of a specific exercise training program in patients with these conditions. And I'll speak to this in that. So first we understood that, as Dr. Alexanderson told you this morning, she's a PhD in his physical therapy background, realizing that exercise in itself is important. And that was the first step. I think we're now realizing that very defined exercise programs are probably important, and the next step is to figure out exactly how to exercise. You don't just exercise. You exercise in a prescribed manner. And what is really intriguing, I'll show you, I believe I have one slide on this coming up, is that exercise doesn't only improve your physical capacity, it actually shows that genes that regulate inflammation are modified up and down appropriately with exercise, which I think is really novel to say that exercise does more than we think. It's not just strengthening or increasing endurance. It may, in fact, have a true anti-inflammatory effect at the gene level. Very intriguing data that hopefully will guide us to give specific, modified, prescribed exercise plans.
Dr. Lisa, are you saying that in this effects of exercise, the patient has both of the Sjogren's syndrome and myositis?
Or either
or. Okay, thank you.
Sure. Okay, so this is a trial using what I spoke to you about briefly before, TNF, which stands for tumor necrosis factor. TNF is one of the many cytokines or these inflammatory chemicals that was first a miracle drug for rheumatoid arthritis, where TNF plays a very strong role. For the first time in a long time, we had effective therapy for rheumatoid arthritis, and as these were the first generation of what are now known as biologics. So the question is, can we borrow these? So infliximab, which is branded as Remicade, is looked at in patients with chronic inflammatory myopathies. And this is a completed trial at the Karolinska Institutet in Stockholm, Sweden. It was a 4-month open trial looking at infliximab. Again, I told you this is the antibody that blocks TNF in adult patients with chronic myositis. Now, I did not double check this. In that group, have included PMDM and IBM. To be honest, I'm not sure that they recruited an IBM, but that was what the original trial was recruiting for. They had to have persisting muscle weakness and inflammatory active disease despite adequate treatment with immunosuppressives, usually either currently or previously. And infliximab is an infusible drug, and it involved only 15 adult patients. And the primary outcome measure that this study measured was muscle function, assessed by a specific muscle function index score, which is a composite score looking at muscle strength. They also looked at outcome measures. I'll go over these in a little detail, but there are specific outcome measures now in almost every trial. For years, we couldn't standardize what all investigators believe we should be looking at across trials. Now we look at what's called the patient's global assessment. How well do you think you're doing? The physician's global assessment. How well do we think you're doing? And on what's called the visual analog scale. So on a scale of 1 to 100, on this line, from here's 0 and you feel terrible to here's 100, how do I think that you are doing? And I'll give my check, and then you give your check. We compare those. Manual muscle testing, when we're actually physically testing the strength of your muscle with provocative testings of each muscle group. A health assessment questionnaire, which is a series of questions that asks you about certain parts of your health and how you're getting along day to day. Your blood levels of CPK, LDH, and extra LDH. These are two muscle enzyme markers. An extramuscular disease activity score, looking at things like your lungs, your gut, your nerves, your skin, and then muscle biopsy, as well as an MRI of the thigh muscles, and a health-related quality of life, something we call an SF36, which stands for short form 36. This is a measure of life quality across all diseases. It's not specific to myositis, but this is all we have for now. So looking at all those measures, does infliximab actually help people in a very small group? We're talking about 15 patients. To tell you about sort of economy of scale, so I review a lot of trials for our institution, and many of these cardiovascular trials that are multi-center trials involve 4 to 8 to 12,000 participants. In myositis, if we get 200 is the largest trial ever, which was the RIM trial, rituximab. So it's a very different scale. It's hard to answer questions with so few people. And the reality is it gets hard to recruit because of certain characteristics that exclude people from the trials, either geographically or others that I showed you on the slide. What about cyclophosphamide or high-dose Cytoxan? I alluded to this morning when we talked about stem cells, and I think it confused people, so let me just take a step back. There are two types of two types of stem cells that were talked about. One is something called a hematopoietic stem cell, which is a hematologically driven, a blood stem cell. Then there is something called a mesenchymal stem cell. A blood stem cell can differentiate into many types of your blood cells. A mesenchymal cell can differentiate into something like bone, muscle, connective tissue. So it's a little bit different. It's different from taking stem cells out of your belly fat and putting them into your muscle versus trying to get stem cells and taking a stem cell transplant into your bone marrow once you use high doses of chemotherapy to essentially ameliorate all your bone marrow. And that's what this does, the latter. It's high-dose Cytoxan or cyclophosphamide. It's something called ATG, which is anti-thymocyte globulin. It is trying to eliminate all of your blood cells, essentially make you back to zero, reboot the immune system, and then use stem cell transplantation in those patients that have refractory myopathies. And this is apparently currently going on at Northwestern University. I truthfully do not know the current status of the trial, but it's slated to end in 1 year. And it's looking at whether high-dose Cytoxan and ATG followed by return of previous collected stem cells, that's from the patients, it's an autologous, not an autologous means your own, stem cells will stop the progression of myositis. And my editorial to this is, I told you, if I had experience of just taking the bone marrow out by itself with not putting the stem cells back, and some of my patients have done beautifully when they failed every other therapy. Please. You are.
For lupus.
Can you get the for lupus?
So I am familiar with the Northwestern.
Northwestern trial.
Yeah, with
For myositis,
Dr.
yeah,
Burt.
but
They, to my knowledge, the only patient that they tried had IBM,
that's interesting, yeah, because I don't have any data that they got recruited in.
and it was not successful. I know I also have lupus. I have polymyositis and lupus, and I'm familiar with a number of patients that have been successfully treated with lupus.
Very much so.
And I think, if I recall the statistic, it was about a 50% success rate.
That's right.
So it was pretty promising, and these people were really out of options.
Correct.
These are very, very bad.
I saw them personally at Johns Hopkins when I
Yeah.
was trained.
So I was treated. I was never treated with that, but I was familiar with Dr. Burt, and I was a patient of Dr. Barr, one of his associates, who's passed away since, unfortunately. But.
Yeah. Thank you for updating me. Yeah, I didn't know that anyone was actively recruited into this yet. I didn't know that anyone was actively recruited yet. I'm sorry, I can only talk to the top. So this is next one. We were a participating site here in which we had 2 patients participate. The early data that used this medication, which this treatment, actually they didn't even like us to use the word treatment, they used this drug, Sifilibumab, which is an interferon. I know those are such hard drugs, right? It's anything that ends in a MAB. MAB stands for monoclonal antibody. So anything that's a MAB, rituximab, sifilibumab is a MAB, is a monoclonal antibody. So sifilibumab is a anti-interferon alpha agent. What is interferon? Interferon is a chemical that goes up in lupus. It's elevated, upregulated in viral infections and in dermato and polymyositis. This was a very unique trial. So the predecessor to this is the open label trial where we extended it. An open label means once the trial has undergone its first phase and it looks to be safe and potentially effective, you can continue out and know your treatment assignment and continue on the assignment that you were in. So say you were in drug category with a dose of 10 milligrams, you can stay in that 10 milligrams dose cohort for a while, and then we look at your data long term. The initial study was very interesting in that the way this was conducted was to screen people's genetic signature, something called a gene signature, and there's something called the interferon signature. And that, in lay terms, is a pattern of genes associated with interferon that was higher than expected in normals. And so if you had the interferon gene signature and a diagnosis of dermato or polymyositis, you were invited to potentially participate in the trial if you met all the other inclusion criteria. This was the first trial that was gene signature driven. So it was a very unique way of looking at medicine. It might potentially be too expensive, but wanted to say that there was validity and wanted to make sure they chose the right people to have the best chance of response. So this was an investigational or interventional trial looking at this particular agent. This was also looked at in lupus. So the completion of this trial will be in March of 2015, but the initial trial did show a reasonable effect. And so this drug may one day, under a different name, be marketed for myositis. So I think that's exciting. I actually realized I have a duplicated slide, sorry. Or is it because I duplicated it. So the next one is looking at rituximab versus, so this is a head-to-head trial we call, so rituximab versus IV Cytoxan in connective tissue disorders associated with interstitial lung disease. So this isn't a placebo-controlled trial, but a head-to-head trial or a comparator for looking at one known standard, and the standard here is Cytoxan, cyclophosphamide. That's a therapy that is, while not greatly tested, well accepted for interstitial lung disease treatment, saying could rituximab be equally effective, if not more? And the reason that this was likely prompted is that there are some initial safety signals that maybe rituximab may actually worsen lung disease. It is unclear. I will tell you as a disclaimer, we use it in patients with interstitial lung disease. I haven't personally seen a decline in lung disease, perhaps in one young man, but it really is the exception, not the rule. But because the thought is that there's some scattered reports, we should really assess the efficacy and safety. So this is a head-to-head trial, and this is actually going on the Royal Brompton Hospital, not here. Apremilast is a drug that's used in the treatment of psoriasis, and they said, well, perhaps it could be used in cutaneous disease. So this is only in patients' cutaneous skin manifestations of dermatomyositis. So this is looking at evaluating safety and efficacy. This is medication given by mouth, looking at skin involvement only. And that is out of Stanford. I do not know if the status is unknown because I don't know if they've even started to recruit data. So on the web, I know that this is postulated. I don't believe it's even started, but I think it's interesting. I was aware of that this drug might be being considered. And so Apremilast is a promising possibility for skin disease. I'm next going to show you data from Yuri Vankowski, who is here, looking at the Prometheus trial. The Prometheus trial was a very simple trial. It was designed in Europe. It's multi-center. You can name all the countries. I'll give you a bonus. So it was started in Prague in the Czech Republic and then also included other European centers. And the goal of the study was to recruit people who had been naive to prednisone, had not seen it or had less than 8 weeks of exposure to prednisone. Does it make sense to give somebody a steroid-sparing agent, which is methotrexate, at study entry, or just to give them steroids alone? So they compared steroids with methotrexate, and what they were trying to study was, could you have a steroid-sparing effect? Would patients use over time a total dose of corticosteroids, glucocorticoids, GC is glucocorticoids, prednisone, prednisolone, between baseline and 48 weeks in the group that got methotrexate first? How beneficial is this therapy if you use it from the onset? And then they looked at a bunch of secondary endpoints, including muscle strength, assessment of disease activity, your muscle enzymes, muscle endurance measured by specific testing. What dose of steroids did you end up on? How disabled were you? What was your quality of life? And then they looked at the number of people that were dropouts or considered treatment failures, meaning that their doctor felt that they were so severe that they needed to go up on their steroids rather than force a taper of steroids down. And what a forced taper means is that you are admitted into a trial, and after a certain amount of time, there's a scheduled taper where you're going to go down by 5 milligrams every 2 weeks. This is something called a forced taper. This is a way to assess and make sure that some doctors are a little more conservative and don't really take you down off your steroids, even if you might be doing well. Other doctors take it down so quickly, maybe too fast. And so this is a trial design that keeps everybody, all investigators, on the same playing field, but the doctor ultimately always has the right of refusal to say, I can't force that taper, my patient's too sick. So this is an open label. It's called an assessor blind. So the person assessing the outcome was blinded to the treatment assignment. This included people with both poly and dermatomyositis, and I just told you it was the physician's own judgment if disease activity was requiring higher doses of treatment. They would be considered a treatment failure. These were previously untreated patients with the exception of steroids, and they could only have been on them for 2 months or less. And they looked at something which all trials now in myositis look at, called a definition of an improvement, or a DOI. This is so confusing. I do this for a living and I find this thing so confusing, but what it says is that there needs to be a greater than or equal 20% improvement in of any of these 3 out of 6 core, of any of the 6 core measures. What are those core measures? First is something called an MMT, which is a manual muscle test. It tests 8 muscle groups bilaterally, both sides, and you get a composite muscle score. This is a test done by an examiner. Obviously, it has some variability. So somebody my size examining your muscles versus a tall man might have a slightly different index. So it's helpful to have the same examiner through the whole trial. There's something I told you about called the physician global score. The patient global score, this is done on a visual analog, saying from 0 to 100, how do I feel today? And then a health assessment questionnaire, your muscle enzymes, and then this idea of this extramuscular activity, your gut, lung, skin, other things other than muscle, nerves. And then no more than 2 of those core set measures can worsen by greater than 25%. So this is the most confusing thing you've ever seen. So you have to have greater than or equal to 20% in 3 of the any 6. 2 cannot worsen, and if it's your muscles, they can't worsen at all. So you can't have any worsening of your manual muscle testing, or that's not considered improvement. Got that? So what is, right, there'll be a test. What is the answer? The total dose of prednisone in the glucocorticoid or steroid group was only 124 milligrams in total over the entire 48-week trial. The dose of glucocorticoids plus methotrexate was 135. So unfortunately and unexpectedly, the group that got methotrexate did not have any better reduction in total prednisone use. What if you looked at the definition of improvement? This is a very busy slide, but so you have steroids. I can't point to both screens. Steroids on the blue, and steroids plus methotrexate in the red. And what that's shown over time is that there was really no difference. But fortunately, 85% in the glucocorticoid group and 86% in the steroid group plus methotrexate improved. There was just no separation of that. So the conclusion is there's no difference in the primary and secondary endpoints. There was good effect in both arms, and definition of improvement was achieved in most people, 85% or better, from week 12 on. And there was no difference between the polymyositis and the dermatomyositis patients in terms of the efficacy, and there had no difference in adverse events in either. So this is a small trial, but it says, should we be using a steroid-sparing agent right from the get-go? And this is early evidence to say maybe not. And I would say that this refutes what I've done for a long time, is to say we have to spare those steroids and use something right away. this gives some evidence to say that, well, maybe you can be on steroids by themselves for a little longer to see if you respond first. Abatacept, or branded as Orencia, is something called a co-stimulatory blocker. It blocks the crosstalk between B cells and T cells. They sort of talk to each other and activate the immune system. The thought is to use this again, you'll see, as I told you, the queen of myositis. So Dr. Lundberg in Karolinska is doing a small trial. This was completed, actually, and the results should be out in the next few months. And the purpose was to investigate the efficacy of this drug on disease activity in both polymyositis and dermatomyositis patients. So borrowing from other diseases, the thought was perhaps this is a unique target in myositis, and if so, this is already on label, meaning that there's an indication for other diseases like rheumatoid arthritis. Perhaps we can borrow this. We do this pretty well. We do a lot of Me Too and we borrow, but I think we have very unique things coming down the pike too, which I'll show you in just now. Okay, this is a giantly, very, very hard slide to read. Let me tell you what it says. This is Dr. Alexanderson's study, Elian and Dr. Lundberg in Sweden, looking at exercise. This is the other exercise study that I told you about, and actually showed some modification of some of these inflammation chemicals and even our own genes that are modified with specific exercise. The punchline is a well-designed, individualized home exercise therapeutic regimen worked well. The problem is, how do we design those individual home exercise regimens for the masses? How do we do that in a setting where it's just being understood that perhaps there are different exercises in different ways to instruct people to rehabilitate their muscles in patients with inflammatory myositis? So I think this is the tip of the iceberg to say that exercise does a lot, probably does more than we appreciate, but you have to do it right and you have to do it in a prescribed plan. Don't have the answer to that, but I think that that is the next phase, is to say, what exactly should we be doing and how should we be doing it? And maybe doing home exercise will work if you have the proper plan. Okay, these are the current US trials available that I'm aware of. The first is topical sodium thiosulfate. Sodium thiosulfate for calcinosis is being used. It's what's called a chelator. A chelator is something that dissolves calcium into the bloodstream, essentially, that then gets, you can urinate it out. The goal would be we can dissolve calcium and take it out by removal through the kidneys. And why do we think about this? What is this drug? Why would we think about it? Is that because in patients with renal failure, with kidney failure, end-stage folks on dialysis often have something called calciphylaxis, where they start to calcify things like their blood vessels, sometimes and devastatingly their skin. But calcium deposition in the blood vessels occurs in dialysis patients because there's an imbalance between calcium and phosphate. And that does not happen in calcinosis and dermatomyositis. There's not a difference in that product. There's no imbalance. Nobody really knows why calcinosis occurs. But the thought was, well, if you could take out calcium in that way, why don't we try it for calcinosis in dermatomyositis? And I initially tried it intravenously, as did others, and it's very hard to dose. It's a daily dose. It often actually causes your nose to run. There are so many issues with, it's just very difficult to dose it. And in the end, most of my patients, while it may have stopped their calcium progression, it didn't seem to make anything regress, and it became just prohibitive from a quality of life stand to use it. So someone in dermatology of the George Washington University, Dr. Ehrlich and colleagues there, she's a dermatologist along with other rheumatologists, including Lisa Ryder, who many of you may know that name, as she's very prominent in juvenile inflammatory myopathies where calcinosis is common. They got together and said, what if we put it on the skin? So they are looking at using laser to actually deliver this medication. So they make a small laser incision, deliver the deliver the sodium thiosulfate topically, and then they use the patient's muscle as its own control. So the place where the calcium is versus the place where the calcium is not, and they're looking to see specific changes in the muscle. So that, I think, it is recruiting now. I've referred some of my own patients there. If nothing else, they do an incredibly comprehensive review and give some options that sometimes we can use as well. But so that's sort of I think a novel way to consider an older medication. Tocilizumab is the drug that Dr. Otis spoke about. He and I believe 9 other centers. We are not a participating center in this particular trial, but I believe there are 10 total centers. You can look this up if you are interested to participate. Tocilizumab is an anti-IL-6 antagonist. Sorry, it's anti-IL-6. IL-6 interleukin-6, another bad actor in the immune system that seems to have something to do with inflammation. Certainly in the joints, it's true. And the question is whether there's some mice models that suggest that, but humans aren't mice. But the thought is that maybe mouse models of myositis seem to have IL-6 as a damaging agent, and maybe we can eliminate that by blocking its receptor. So this is a trial that's ongoing, recruiting now out of the University of Pittsburgh, and this is both PM and DM. And people who have refractory disease, meaning you had to fail at least one prior therapy and usually two. This is an open label, it's called proof of concept study, looking at efficacy and safety of Acthar, or ACTH gel in refractory dermatomyositis and polymyositis. This is also Chet Otis's investigator-initiated study. This is recruiting now as well. And they want to evaluate whether ACTH gel improves the symptoms of this disease. This is really this is a hot topic, a complicated topic. This is a very unusual circumstance in which we have an FDA-approved drug that does not have a lot of data behind it. And in full disclosure, I told you I've consulted for this company, and I think appropriately they're trying to get data in different ways to say, does it actually work? Part of the way to get that data is to try it in people and gather registry data, but a more appropriate way probably is most likely is this, in which there is a trial to assess it in a very rigorous fashion, to actually look forward, look ahead, and ideally to see if it's an effective therapy. The cost of this drug has been very controversial, and as I say to others, that many of the third tier, to me, are the higher line therapies, the therapies where you've graduated to not just responding to something as simple as azathioprine or methotrexate or maybe even mycophenolate, which is Cellcept. When you're graduating up higher, looking at rituximab, IVIG, and Acthar, I can say empirically, I think IVIG and rituximab have shown some benefit. I think Acthar needs more data. All of them are in the very, very high price range. So I think we also just need to speak about that as in general, is how once these drugs show efficacy, how we really bring them to everybody, because the cost is very prohibitive in many. Next is a double-blind, randomized, placebo-controlled study to look at safety, tolerability, efficacy, and a preliminary dose response. So I didn't speak a lot about dose response. What that is looking at specific dose cohorts. So they'll have, in this trial, 0.52 and 10 milligram dose cohorts, as well as a placebo group. This medicine, this investigational therapy, this BAF312, is, as I told you, is the drug that helps prevent egress or exit of lymphocytes. The thought that some lymphocytes go to a site to injure your muscle. The thought is if we keep them in the organs from which they started, like the spleen and others, they then will not get to the site of injury. So this is something called a sphingosine-1 phosphate receptor modulator. This is totally new. This is something that is very novel. It's a novel target. They're thinking outside the box, and it's a very novel way of thinking about maybe trying to stop the immune system in a way we have not. This is a Novartis-sponsored trial. This is the same exact thing in polymyositis there. We are a participating site, as are many others. They're actively recruiting now, and we're hopefully going to be up and recruiting in the next few weeks. IDERA, who is here, this is their newest concept. There's a phase 2 randomized double-blind placebo-controlled trial. This is called IMO 8400, and this is a inhibition and blocker of something called the toll-like receptors, TLR 7, 8, and 9. Let me just suffice it to say, this is their slide. I send it up to you if any of you want more scientific information. But how TLRs work, without having a full immunology lecture, is that they directly contribute to this ongoing muscle inflammation. It's a cascade in which they think that damaged muscle expresses these particular injured muscle cells, express these toll-like receptors. They're initial, and so they're a pro-inflammatory cascade. So ideally, blocking the activation of those would block this pro-inflammation going forward. There in other way, some of the toll-like receptors help with bacterial infection and others preventatively. So there are some good parts to the immune system to toll-like receptors, but many of them can become deleterious in muscle disease. That is it. I gotta breathe. I'm gonna take a drink, water, and I will point to my shameless plug for our Myositis Center. I point to the bottom. Will Kelly doesn't know, but I have a fantastic research assistant who his name is Will Kelly. That's the number. So if you express interest in any of the last 2 trials, we're participating. Thank you so much. I like this. I need this at home. Are participating at our center in the IDERA study. We will be hopefully participating soon, as soon as we're up and running with that. That's the TLR study that I told you about, and BAF 312, which is this lymphocyte prevention trial, and the many others that I shared with you locally, hopefully to you. That's all I got. So.
On the ACTAR,
Yeah.
you said that Dr. Otis is doing one. So is this, and is Dr. Todd Levine doing one also?
So Dr. Levine's study is to look at those patients who are already using ACTHAR, and to collect the data just in specific ways to try to get information of those already using it. So it's not a trial. He's not testing it against something else.
So would he be taking Dr. Otis's information and
I think the answer is yes. I do think they'll share. Any clinical trial will be shared with Dr. Levine. I have an interest to do it myself, to be honest. It's hard. I'm one person, but the idea would be to look at that versus other therapies that we've tried. I think that it's an important agent to consider, but I think it needs to be looked at rigorously, as does the company. I think they support that as well. I'm not ready in prime time to advocate for it one way or the other, but I think that it has promise if we look at it in appropriate ways.
Thank you.
So what do I know about, or my opinion about, using ACTHAR for only 3 months? So there's no good data. What's used, as you know, is the 80 units twice weekly, just because Dr. Levine used that when he saw in other neuromuscular conditions it had been used. I'll just give you a very brief, I know this is not an ACTHAR discussion, but I think you guys probably know this because the company has I think, been very visible. But so some people feel, well, ACTH gel should just be a glorified steroid, and wouldn't it just be a steroid? And the idea is, where this became novel is that there is an neurologic disease in children called infantile spasm, which sounds completely benign, but it's awful and can lead to mental retardation with time. It's a devastating neurologic disease in children. Many of those children do not respond to steroids, but do respond to ACTHAR. And if it were a steroid effect only, the thought is, well, why would a drug that has a just bioidentical to steroids matter? And the thought is that it's the melanocortin part, the melanocortin stimulator, MSH. It sees that too. And so there's a story here, I think an intriguing one, but we don't know the dose. We don't know the length. I don't know what it means to be on it for only 3 months. I myself have done that. And there's someone in the background saying, yes. Go ahead.
I was on ACTAR, and the initial dosing regime that Todd Levine is using did not work for me. So we kind of figured out what would work, because I found I went up and I went down and I went up and I went down. So we went back to an every other day and a much lower dosage, and that worked great for me.
What is the dose?
I'm also on QuestCore's patient advisory board, so I was able to give them this information as well. But they said just what you said. Todd Levine is, they all use the same thing. They followed his.
Yeah.
But if you can get your doctor to work with you, and QuestCore said, it says on the label, as directed by physician. So you can, under the FDA standards, kind of, I can't think of what the word is, but I'm trying to find, acclimate it to your own body as to what works for you. And I did experience a tremendous amount of improvement when I was on it.
A
tremendous amount of improvement. My muscle strength was better. My fatigue went away almost completely. But when I was doing it at the initial dosing rate, I had all this energy, and then I would just crash. And then next shot, go right back up and crash. But when you spaced it out, kind of like, the IVIG, some people can do it for 3 days. Some people have to do it once a week. Right. I was a once a week person.
I think that's very helpful. And that to me says that we just need more data. People like you in a dosing cohort, a scheduled cohort, and figure it out, because there may be great success. I just don't think we know it.
It feels kind of funny to be asking this because you and I are working together now. But I'm going to ask this as though I was a year ago, before I had worked with you. One of my concerns with all the new drugs is that, you know, before we modified my medications, I was on prednisone, Imuran, methotrexate, and IVIG. And I always had the question, what would happen? How do I know which one's working? And how do I know whether maybe 2 of them are working and the other 2 are along for the ride, and maybe 3 of them are working and the other one's actually not helping? So as these new drugs are coming out, I'm curious about whether that is an issue that's being addressed for the trial patients. In other words, if I'm already on drug X, Y, and Z, and you want to put me into a trial that's going to test A, you know, how do we know whether A is working because it works well with X, Y, and Z, or what?
The best, says a long question, but the short answer to that is that what these trials try to do is allow almost no background drug, or if they do allow it, they compare it in X and Z. So either they allow you to be maintained on something like methotrexate in a lower dose, or your dose, and they allow that across both the treatment group and the usual care group, or they try to eliminate it altogether. Ideally, the cleanest study allows you to only be on background steroid and nothing else, but it's very hard to recruit people in there because it's just not a clean disease. By the time you're going to a clinical trial, you've tried a lot. People don't enter this, get diagnosed Wednesday, and then Friday are in a clinical trial. A, it's probably not ethical to do that, and B, it doesn't work that way. We have a harder time recruiting in a clinical trial patients who haven't had that. So I don't know the right answer, except to say that there are a lot of statistical ways to try to control for that and figure it out. But this idea of synergy between drug X and drug Y, I think it's underappreciated. It's unclear. It's very hard because the numbers are so small. So your question is a good one, and I don't think we have a good answer. You're right. The prior question you asked is a little easier. If you're on 3 drugs and you say, how do I know if it's all 3 drugs, 2 drugs, or 1 drug? And what I do is I peel them off one by one. So I try to peel them off and try to make it cleaner, take off one slowly, wean down, and or take it off saying, I don't think this works. And then part of the way I do it is I look back and I try to figure out how things were added, and do we really see both objective and subjective measures of improvement? Do your numbers look different? Do you look different? And it's hard because you're going back in time. So trying to just make it as clean as possible by removing those drugs one by one by one and saying, oh, you're right. And I have done that. I've insisted that CellCept was not working, and I said, this is just not working. We'll just peel this off. And then the patient calls and says, I'm definitely worse than it was working. And there's validity to that. You can't always tell. And my patient and I together have sometimes said, wow, we really underappreciated the effect of that drug. So sometimes it takes you, the danger in that is occasionally when you take someone off, when you put it back on, it doesn't work as effectively as it did before. That happens sometimes in my experience with IVIG. And I don't know why. Sometimes I need a holiday off it, or try it again, or try a different brand. I don't know. That's just empiric data, just looking at it. That's my gestalt. So they're very hard questions, and it's a good one, but I think it's complex. Please.
Hi. I've been on Actor 2 and did not have success with it. I just did the standard 12 weeks bi-weekly injections. But my question is, on a similar drug to Actor called Synactin, which is the synthesized version of Actor,
Yes.
do you know if there's any plans to test that in DM and PM patients?
Maybe possibly in Europe. So my recollection is that that drug is only available, or is available. It's a little different. It's not the same length as far as it's biochemically a little bit different and doesn't include as much as MSH as the Acthar formulation does. But I think they're probably looking at that in Europe because that's much more likely to be available there. But no, I don't know of any plans to test it here. I would doubt it because it's a competitor, so I don't know. Yes, but they don't market it here, so it's interesting.
If you're on 60 milligrams of prednisone and you come off 5 milligrams a week, is that a safe taper?
That's a hard question. So the question is, if you're on 60 milligrams of prednisone, you taper by 5, That's a very hard question. I'd have to ask how long were you on it to begin with? Why were you on it? For which disease manifestation? So I taper pretty rapidly. Again, this is more of a treatment practice answer than a clinical trials answer. In general, in clinical trials, we don't taper that quickly, so it's probably a little brisk. But in the beginning, if you're on a high dose of steroids and things quiet down, I taper pretty fast. I actually can taper down by 10 quickly every week. So sometimes I'll go 60, 40, then come down to 20 a little slower, then go real slow, 20 to 10, and super slow, 10 off. So 60 to 40 is not a big jump, believe it or not. 40 to 20 is. 20 to 10 is worse, and going from 10 sometimes can be the hardest thing. So it's a hard answer. 5 a week can be fine if you've been on it a while and they're trying to get you down quickly to 40. I think that's not impossible to do. But to continue that taper to off would be too fast.
Some first-time attendees just asked me if I had to do it all over again, what order would I have done the drugs? Because I've done Rituxan, I've done IVIG, and I've done the Acthar of the top-tier drugs.
Yeah.
And I said I would have done the Rituxan first, then the IVIG, and then the Acthar. What is your perspective of what is the best order to try these?
Again, that's such a hard question. So the way that I usually order those drugs are often based on the person's antibody. For example, in my experience, rituximab can be extremely effective if you have an SRP antibody where nothing works. IVIG is helpful if you have statin-associated anti-HMGCR antibody. I'm telling you, I might be talking like things you've never heard of before. But we look at things in such a granular fashion that's not an easy answer. So I don't think there's an order. There might be an order for certain things. I think IVIG is a very effective therapy. It depends. If you come in and you can't swallow and you're going to get a gastric tube, a PEG tube inserted, I'll give you IVIG on the spot because I think it works faster. I'm not going to give you Rituxan. But rituximab might be perfect for somebody who has an overlapping rheumatoid arthritis and bad disease. So that's such an individualized question. I don't know that I can actually answer that with any great clarity. It's more individualized answer, I think. And the PML, which is I joke that I talk about rituximab. Sorry, I have to go to a focus group in a few minutes. I joke about rituximab, and when I always try to make sure the patient is well informed. I give them a written summary of all the things that these horrible things these drugs can do to you. Mostly they're very safe, but they really look bad on paper. And I discuss rituximab and say, in my personal experience, it's very well tolerated, except for there's a fatal brain disease. If you get that, you die. I mean, it's tongue in cheek, but I have only seen it once ever, and it was a very, very severely ill person. But I think it's a risk-benefit issue too. Some people don't want a blood product because they don't want the potential exposure. Other people are not going to take the chance if they're 1 in a million to get PML, this brain disease that is very rare, but they won't take the risk. So sometimes it's an individual patient discussion as well about risk-benefit.
I just have a general question.
Sure.
I'm off totally prednisone.
Yay.
And I'm on Imuron for about 2 years now, and he now wants to start weaning me, which I find it so scary. But say, for example, I'm just on the Imuron. Do I qualify for a clinical trial if I chose to want to do that, or are clinical trials for newly diagnosed?
Yeah.
Or I still don't know how. I know there's specific requirements for each trial.
That's exactly right. And some will allow you in, some would not.
And I read in the Myositis magazine, or what they give us, they mail to us. There was one I was quite interested in. I can't remember, but it was by Novartis, and I could visit, say, in Irvine, somebody there. But it seemed like I was at that window that they wanted someone 2 years and under, and I was just 2 or something of that sort. So I didn't qualify for that. So my general question is, do I qualify if I ever am off it and say, for example, I start feeling something weaker and I say, hey, Dr. Wu, can I do this clinical trial? Would that be appropriate?
Yeah, it is appropriate. The answer is maybe. So exactly that. Say your disease length is too long and they're looking for newer, less than 2 years of disease, so yes, no. Sometimes they don't specify because these trials are hard to recruit for. We try to make it as inclusive as possible. And the answer to just therapeutically decreasing your drug after 2 years, if you're in remission in the sense that you do not have any ongoing symptoms, you're labs look good, you look good. I do try to taper. I had one patient who had seen somebody else for years, and they said that she said she would never get off this drug. She was only methotrexate. And I said, it's time to wean it. And she said, but I was told I should never wean it. And I said, well, I'm telling you, you should. And we fought for just a year back and forth, and she's off drug. I mean, it really took her a long time to trust that you could get off a drug. Sometimes you can't, but I think it's always worth a trial to very gradually wean off drug. But many trials don't require that you're off something like, most of them allow a background, many, not most, many allow background methotrexate, steroid, or azathioprine, which is Imiran. Many, not all. It was a good group. Thanks. I hope it was helpful. And normally I'd stay, but I have to run a focus group. I have 5 minutes, but I really have to be good about the time because I have to put together focus group packets. I'm so sorry. Yeah, so do we recruit other people? Yeah, thank you for caring about my mental and physical health. I appreciate it. Yeah, I'm going to stop seeing new patients for the first time in my life for a long time because I'm saturated. I actually physically can't do it anymore. So I'm going to have a small time off seeing, well, maybe up to a year. I have two phenomenal rheumatology colleagues, one of whom I actually hope she's here someday, is Dr. Maima Albeida. She's fabulous. She is great. I mean, if you have seen her, she is wonderful. Yeah, she's fabulous. She is the up-and-coming generation of myositis. I love her. I love to watch her work. She's great. Dr. Julie Pack has worked with Dr. Andy Mammon and has done some work in scleroderma myositis overlap and has a background there. Also a very talented rheumatologist. Yeah. And I know Dr. Albeida's wait is long. She's wonderful. She's wonderful. And then we're trying to expand our neurology horizons with Dr. Mammon leaving. Now, he's not ever really left. He also has the capacity to potentially see some news. Comes in twice a month right now as an adjunct member. What Andy Mammon's departure has allowed is that we have a collaboration now across the state and allowing him to do some very innovative research, certainly I think in the future genetically, which is really exciting to me. So I have